it's not gonna work.
Oh, absolutely not, but I'm just saying if you, when you're going forward too, like you take these cases retrospectively and maybe also learn something going forward, one of the things is are the families, depending on who it is, really understanding when they do this informed consent, how informed is that consent, do they understand it? Because in that, from a prospective way, to maybe prevent some of that, because things will happen, how is that explained? I'm
You
not
bring
saying
up
it wasn't explained here.
Bring up a good point. So there was a study done in Mount Sinai. They looked at patients who had an elective tracheostomy after prolonged ventilation, and they looked at 5 ICU units there, and they asked an 18-item questionnaire about tracheostomy, what it means, what are the complications, what's the functional status after tracheostomy, what is your expected mortality, what is your expectation when you go home. Like really basic things about informed consent. And out of those 18-item questionnaires, maybe only half got a third of the questions answered when they polled caregivers about, hey, and patients like, did these questions get asked to you after a tracheostomy? So then we do the trach, we say everything went well, we got informed consent, but did we? Right? And it was shocked the percentage of patients that didn't get asked, what is your functional status after a trach, or your chance of being hospitalized, or the chance of dying. Similarly, when in that neurosurgical case, we tend to get a lot of visitors from other countries that happen to show up in our emergency room. You know, and it's a lady with a glioblastoma, and so the surgeon, a blessed neurosurgeon, they said, you know, it was Friday night, look, I don't think we should operate, I think you need a palliative care consult. And they said, no, you have to fix her. He said, so he succumbed, he fixed her, evacuated some of the tumor, some of the tumor was still left. And she had a hemorrhagic conversion. And things went bad. And then he jumped to the next thing, which is trach and peg. Case management stopped him, saying, look, you need to get a palliative care consult first. Let's just get palliative care involved before we do the trach and peg. In the silos of a crazy, archaic academic medical center, the trach and peg wasn't, stopping the trach and peg wasn't communicated with the ENT. So the morning I was about to walk in to do the consult, she already left to go to the OR. Timing. And it wasn't stopped, so she got the trach and peg. We were furious. I even went to the CMO's, the chief of staff's office, like, well, what's going on here? So we have an undocumented, illegal patient who, now we have a trach and a peg, nobody's going to take her. I mean, cost issues were huge here, but we did a trach and a peg on a patient which was that shouldn't have even been operated on. So then the family gets a message, oh, she's going to get better. And then the family's suave enough to know, oh, now you're getting palliative care involved and you're trying to kick us out because we don't have insurance. Right? When right in the beginning, if we did fully informed consent of what it means about this tumor, and I mean, they can't sue you for not doing surgery.
Right.
There's no basis there to sue, because you know this is an inoperable tumor. You're doing a palliative approach on a patient which a lot of people would say you shouldn't even operate on. You should offer palliation, right? And then getting palliative care involved way too late. So that was a fun one. So you know what we did? We actually long, prolonged course, and the amazing thing was she was in our neuro ICU for a month when she didn't have to be, and of course now her tumor had a full expansion, right? Because she didn't have her skull, so the tumor had a lot of room to grow now. So we actually prolonged her misery. We actually airlifted her to Honduras. We paid. And she was on a vent, and we actually got a Honduran physician to accept her.
Did you fly with her?
No. It was actually one of the most dangerous airports to fly into, because Honduras is pretty scary right now. So the family said, well, if she goes to Honduras, she'll die. And we said, that is correct, and she will die here too. But at least here she's on a ventilator, and over there, they have 2 ventilators in this hospital for how many hundreds of patients? He goes, you're absolutely correct. They do, they only have 2. It was, well, they're gonna take her off the ventilator there. I said, you're absolutely correct. He goes, that's what we should be doing here, because there is no medical benefit for continuing the ventilator here.
This was a family member or something?
Yeah, he was a businessman. I mean, he knew English. I mean, he was pretty. I mean, he was here for a conference in Chicago. I mean, he was pretty with it, very very educated. But you know, it was a tough one because we basically had to send her back to her country to die when she could have actually died much more peacefully. And we were ready to take her on home hospice and cough up the cost because it would be we would write it off and everything would be charity care.
So it would have been a lot cheaper than the
Flying.
$50,000. And we actually flew somebody to India too.
We have one in China.
Huh?
China.
We did an airlift to India too, undocumented. Yeah.
And the Air China calls them, are you sure? No. You're responsible for the station.
So,
But
yeah,
yes,
they,
that's something I didn't know.
We booked like 9 business class seats on Etihad Airlines. This is a really nice airline to fly
She
business
actually
class
did
on.
well. The husband wanted her to die in China. I said, okay, no.
Yeah. All right.
So the third case, service admitted 80-year-old woman, worsening renal failure, pulmonary edema, stage 4 CKD, diastolic dysfunction, aortic stenosis, not responding to diuretics, complicated course, creatinine's 5.5, cardiology and nephrology are helping you manage the case, but there's not a whole lot they can do that's non-invasive. 2 years ago, she was saved by acute hemodialysis after having pulmonary edema and ultimately recovered from that. And that's something that the patient and family perceived as being of value. She has capacity to make her own decisions, but she defers to 2 children, and it sounds like you're sort of locked in the least common denominator of accepting, you know, advancement of aggressive measures when they don't completely agree on things. They understand that she's developing end-stage disease, and they're concerned about the negative impact of chronic dialysis. But when she gets breathless, she gets chest discomfort when she's volume overloaded, and that imparts a lot of suffering. So they, you know, at this point, dialysis is on the table. There's a concern that the patient will die in the hospital without it, and they wonder if you couldn't just initiate hemodialysis now, render the patient eulemic, and then quote-unquote see what happens.
It's a pretty similar theme. What's their understanding of the medical condition? What are their goals? And do they want to see that, it seems like they understand she's suffering. So there's something there where the underlying theme here is I bet their goals are comfort, right? Their goals are comfort, but they see not dialyzing as drowning in your own death. Well, just take the fluid off and get it all off, and then we'll see what happens. Well, that's the part where they need our honest, compassionate communication on that's not an easy thing to do. Like the consult I did yesterday said, you know, we can dialyze, but do you know that it gets harder and harder to dialyze as we go on, as a liver failure gets worse? Why are our kidneys failing? Oh, because of the liver. Can we fix the liver? No, we can't. I understand that, Doc. So do you think we can fix the kidneys? No, we can't. And you understand how hard it is to dialyze, how hard it is on him when we dialyze, and look, oh yeah, he was so awake and look, he's sleeping down, he's so weak. I go, that's from the dialysis. Oh, really? Okay. So, open-ended questions circling back to them, making sure that they understand. And saying, look, I wish that I could magically remove this fluid, but dialysis will not do that.
So let me ask you just a couple of follow-up questions, and anybody can chime in here. In a case like this, first of all, this morning you presented a fair amount of good evidence about ESRD and about elderly patients and the patients in this age group and the outcomes of dialysis. Is it your practice to share that evidence when you talk to patients? And my other question is, let's suppose you commonly agreed with this family that you would you'd avoid further hemodialysis. What do you do from a symptom management perspective when this patient becomes volume overloaded and is breathless the next time?
So, do we give evidence? So we don't quote numbers, but we say the evidence shows that in this age group, starting dialysis has a very high mortality rate. We also have evidence that starting dialysis really dramatically changes what we call functional status. Can we talk about functional status means? What is the functional status of your mom, and what does quality of life mean? And again, going back to goals. Secondly, we say, you know, I understand your concerns about her drowning, and we don't want her to suffer through that. By not dialyzing your mom, there are other measures we can take to ensure that she's comfortable, and that will provide the morphine. Oh, you're going to kill her with morphine. You got to massage that message about what morphine's use is. I thought morphine's only for pain, or only addicts use morphine. No, actually, we use morphine quite a bit for patients who are breathless. Because, and you can also say, look, at one point, I medically cannot dialyze your mom because she won't tolerate the dialysis, her blood pressure will drop, and I will do more harm. Not I can do, I will. Wording. I will do more harm, and I cannot do that to your mom. Does that make sense? He was, oh yeah, no, doctor, you can do more harm. I said, medical technologies have their limits, and the body can't handle dialysis. So our only alternative is to give medications to focus on her comfort so she's not having the sense of drowning. Number two, you can also talk about how every doctor wants to die is through uremia. Right? You
Well,
can.
the other issue to this is, I mean, I know this is more symptom management, we have to get her symptoms under control.
Right.
But just in general, with end-stage renal disease, the interesting fact is that a lot of patients that have been going home that have either stopped dialysis or never initiated dialysis are going home with home hospice and actually surviving.
Yep.
For quite a bit of time.
Absolutely.
Some to the point where we had repeated, finally 6 months down the line, repeated blood work on them, and their creatinines were back to baseline.
I feel
So, so the dialysis would have actually killed them.
Right.
Because they wouldn't have tolerated it for very long. And not having dialysis actually allowed them, some of them still died within a month, 2 months, 3 months, which also was not expected. They were expected to die within a week. Or some of them actually survived.
On our boards, we're told the answer is weeks
Yeah.
when you stop
Yes.
dialysis. But you can talk about the fact that the kidneys are not the problem. It's the other issues that are causing the kidneys to fail, right? Try telling nephrologists that.
But also they have better
No, yes.
quality.
Like I said,
too.
most
The
of them
other
still
part of the
die,
conversation.
although not within days always.
Right,
They
right.
still, some of them are
But with
going
less
home,
suffering.
doing their thing for a couple of weeks, and then they
Yeah.
die with less suffering, obviously. That's,
Yeah,
and-
and
and-
money for the family.
but
Right.
some of them actually survive a lot longer.
There's a big misconception out there, maybe even among physicians, that the dialysis is going to save the world's problems.
Yeah,
Oh, yeah.
the dialysis is a savior, and that's where I tell them, look, dialysis may actually kill them a lot quicker than
Like
you
this
expect.
family had to see, and it's actually good, we see the consult right after dialysis. Although when I was doing, it was not ideal because he wasn't communicating